네, 30분 돼서 시작하겠습니다. EKG 컨퍼런스 시작하겠습니다. 발표자 강사 1년차 정재영입니다. 이번 주에도 타키카디하고 레이트 203회 정도의 와이드, 네로, 약간 보더라인 정도에 있고 RBBB 패턴 보이는 라이트 엑시스의 EKG입니다. 와이드 큐안스 타키카디아 보이는 것 같은데 업무계 선생님 혹시 힘든 거에 대해서 제일 가까이 앉아 있으니까 되게 많이 보냈어요. 답을.
일단 설명해 준 와이드 큐아레스대로 타키카디아 소견을 보이고 있고
와이드 큐아레스 내로
와이드 큐아레스타키카디아 소견을 보이고 있고
와이드 맞죠?
그리고 색깔 이상 대부에서 와이드
일단 뭐 V원회를 RBBB 패턴으로 보니까 RBBB로 보이고
제가 봤을 때 일단은 지금 원 쪽에서 그 RSR 트리페이지로 보이고 그리고 V6 쪽에서는 이제 RS 레이쇼가 R 쪽이 더 큰 쪽으로 있어서 이런 점은 좀 SVT 쪽을 페이버 생각을 합니다. 그 P웨이브는 어, 리드 3 쪽에서 좀 관찰을 해볼 수 있을 것 같은데 P웨이브에 좀 얹혀있는 듯한 그런 P웨이브 몰골을 처음 두 비트에 보이고 그 다음에는 다시 잘 안 보이다가 일곱 번째, 여덟 번째에서 좀 다시 보이는 것 같아서 어, 그 어베런시를 보면 SVT 쪽이 좀더 가능성이 있다고 생각합니다.
So what is the differential diagnosis? It's just SVT with aberrancy, or there's something else? So let's give you an example. Why this cannot be left anterior fascicular VT? Anything you think that is could be against it or favor it? Just opening the discussion for you to start thinking.
영진 선생님이 할 말이 있는 것 같습니다.
Okay.
리드 V2에서 QRS 모양이 한 번씩 달라 보여가지고
That's correct. And then also in V3, your width of a QRS get differ. You see that same bit you're talking? Look at the V3, V2. Next bit. No, yeah, that's that. No, you passed that one. You see that terminal R in V2 disappear. And that happening also right a second bit after that, two bit after. One more to the left. Or keep going to the right. You had the first and normalize again, and the next one. See, the same thing happening, but different degree. Then also in the terminal QRS, there's a notching, very unusual notching. You see it? In the V2, first, third, fourth complex, 네 번째 컴플렉스 가시면은 거기 조그만 너칭 있지 뒤에 터미널 그게. 예, 그 다음에 가서요 그 다섯 번째 가봐.
네.
예, one more. Yes, 그 너칭이 바뀌었잖아. 그지 계속 바뀌어 이 너칭. Why is that? 이게 aberrancy면 이게 consistent with that?
이니셜 교환에서 40ms/s에서 보통 리드2나 V6에서 보이는 Q 웨이브도 있었다 없었다 하는 게 SVT의 가능성은 조금 떨어져 보인다고 생각을 합니다. 적어도 히스트
그러니까-
그 아래에서 오리진 해야
Right.
분명히 될 것 같습니다.
그러니까 우리가 지금 생각해야 될 거는 we need to prioritize what is our differential diagnosis. 그 다음에 B6 가시면은 B6 second to the last 맨 마지막 2 second bit 봐봐 B6 그 위에 그 바로 그거야. 가봐 B6 No, next bit. Yeah, 올라가. Is the same as the other guy? V6. Precordial V6. Yes, that bit. Look at the initiation, how they start. There's no Q wave in this complex. Other ones, they have a Q wave. 없지? So what does that mean? Can you have if this is an aberrance SBT, O, BT, which one they most likely have a different patterns of a Q wave at the beginning? SBT or BT? 왜냐면 그 QRS가 morphology가 change 되는 거는 there's a possibility of there's another complex lying the top of it time to time. Am I right? Summation effect가 돼서 그렇게 되는 거 아닌가? 그렇지 않으면 QRS가 바뀔 수가 없지. 에버랜스는 똑같이지. So that also this open discussion about whether this could be, as we said, some sort of a tachycardia, ventricular tachyarrhythmia with the intermittent dissociation. That's also possible here, right? 근데 이제 what determined that summation effect? Let's say this is SVT. That's correct. That's a diagnosis. Let's assume that's correct. If your RR interval change, then we could have a transient sort of a, not dissociation, but a timing difference between two activation. But in my eye, that RR interval looks the same to me. That's not changing much. Anyone disagree with that? It looks like RR is very stable, right? So then we need to explain how can we explain this complex has a different morphology that you clearly see in B5 and B6. I think there's a P wave. Okay? During the QRS complex, what does that mean? Is absolute refractory period of ventricular activity, right? Only way to change that, you see summation recording of a P of activity, ventricular tachycardia going on, then you have what we know as a VA dissociation. That's most common. The other explanation is that you had a different degree of aberrancy, but that doesn't explain why the Q wave would disappear. Any other observation we can make through this ECG?
그 세 번째 비트랑
Aha.
그 리드 2의 세 번째 비트랑
Lead to?
밑에
Yes.
네. 세 번째
Yeah,
비트의 QRS 바로 앞에 있는 조그마한 험프가
Right. That's the same thing. Yeah, that's what we've seen. But you see more pronounced than B5 and B2 and B5, B6. That's what you see more.
그 열 번째 비트의 ST 세그먼트 초반부에도 약간 험프가 있어요.
Uh-huh.
저게
So there is some sort of a non-consistent pattern that is altering our QRS complex time to time. Right? So that is could be ventricular tachycardia. But what kind of ventricular tachycardia is so narrow? Typically?
저기가 그 리드 1이 네거티브 2,3가 포지티브라서
Right.
그러니까 포스터 사이클 블락이
No, it's not I did not say posterior fascicle.
예,
Anterior fascicular VT can do that,
예.
right? Yes.
예전에 혹시 그쪽으로 어블레이션을 받은 경우에가 사실은 흔히 말하는 septal fascicular ability가 호발하는
Right.
조건이라서
So sometimes, as you said, posterior fascicular VT patient, even during the EP study, you can induce subtle fascicular VT because of many many septal fascicle are originating from posterior fascicle, more than 60% of cases. Therefore, depending where you're pacing from the fascicle, posterior fascicle, you can create reentry. It's well known and is well described by the Milwaukee group many years ago. Patrick Chu wrote a many paper about it. And then also, matter of fact, there's an interfascicular VT. They published many serious cases. So we have a two possibility here. One, AB or SVT with some sort of aberrancy, right bundle aberrancy. But it has to be typical aberrancy pattern. This is what you see in the right bundle branch block. alone can explain QRS complex morphology here? Or do we have some other conduction abnormality involved? For example, posterior fascicular conduction delay or anything like that? Yes or no? Lead 3. Do you see typically such a tall R wave in bundle branch block? Right bundle? You don't. Lead 3 should be lower than R wave compared to V2. Lead 2, I mean, via the right bundle branch block pattern. Because of the right bundle branch block delay, mean your inferior lateral are going to be delayed further down. Therefore, R wave should be smaller, shorter than lead 2. Because the wavefront of propagate from septum to the lateral wall to the right ventricle. In that regard, what happened? Your S wave also get wider. Okay, that's a typically a normal right bundle branch block pattern. This is not a normal bundle branch block pattern. Okay? So we have a problem with that too. Make sense? What I'm telling you?
네.
Because lead 2 is more leftward orienting lead. Lead ABF, lead 3 are more inferior lateral. Therefore, impulse propagating delay conduction activation time to the right free wall, yours should be R wave should be smaller. Not almost same as lead 2. And then also S wave too narrow. S wave should be widened. Okay? So pay attention to the right bundle branch block, EGM again. Okay? So this is a atypical pattern of right bundle branch block patient has, and they relate to a narrow QRS complex, considering BT, but SBT certainly not, is wide. And you have an intermittent QRS deformity changing time to time. Suggestion of maybe there's some dissociation between two complex activity of atrial ventricle. So who favor for BT? How many of you guys in there right now? I see 1, 2, 3, 4, 5, 6, 7, 8 of you, 9 of you in the room, right? So don't you guys always vote for this? Who favor for SBT? This is this is an educational thing, okay? It's not a life-threatening thing. So you can tell us what you think. That is important, so we can discuss clear your question, okay? This is education is about. It's not about we're trying to intimidate you. It's a very friendly conference. So anyone favor for SBT here? Well, also if you look at the carefully, all the T wave change morphology is not exactly the same. Keep changing T wave. So probably there's another wavefront in there. Look at the leader 2 bottom tracing, continue tracing. Bottom, yes. Keep looking at the T wave morphology. That's slightly different. Sometimes someone looks a little wider, some looks narrow, some looks as notched, right? In SVT, you could not have that because this is a repolarization, absolute refractory period as well. So you should not have any other change deformity unless there is some second wave hidden inside, which could be a dissociated P wave. If the SVT was regular tachycardia, your T wave shouldn't be changing as segment and T wave. Okay.
선생님, 제가 한
History.
말씀
Let's go.
좀 첨언을 드리고
Yeah.
싶은 거는 제가 생각해도 선생님 말씀에 전적으로
박현아
동의하고
선생님 들어오셨어?
8시부터입니다. 다른 컨퍼런스가. 근데 그 VT
그래?
가능성이
Okay. Alright.
훨씬
Okay.
높다고 저도 생각하지만은 펠로우들이 EKG 인터프리테이션 할 때 꼭 한 가지 염두에 될 것은 EKG라는 것이 하나의 probability이기 때문에 확신 있게 이걸 BT다 SBT다 하는
Right.
거는 좀 조심을 해야 될 것 같고요. 특히 이런 와이드 QRS 컴플렉스 사이에 AB 디소시에이션이 있으면은 굉장히 highly suggestive BTA 소견이긴 하지만은 컨덕션 디즈가 있어서 그 SBT의 variable 컨덕션이
Right.
있는 경우에는 꼭 이게 PAV VA 디소시에이션 같이 보일 수가 있으니까 꼭 조심할 필요가 있고, 그래서 아까 아마 황 선생님께서 regularity에 대해서 강조를 하신 것 같습니다. 그래서 인터프리테이션 할 때 그런 부분을 꼭 염두에 두고 하면 좀 고수답게 인터프리테이션 하실 수 있을 것 같아요.
그래서 항상 그 differential diagnose를 하는 것이 중요하고, 그 다음에 EKG를 조금 더 디테일하게 보면서 계속 이런 exercise를 하시면은 you will be good at it. Okay?
네.
Alright. 갑시다.
네. 사실
History.
정답은 히스토리에 이미 있으신 분이긴 합니다. 그래서 환자는 18세 남자 환자고 2019년에 처음에 축구하던 중에 하트레이트 230까지 오르면서 처음에는 타병원에서 PSVT로 의심을 받고서 계속 팔로우업을 했었고 그 이후에도 계속적으로 운동 시 또는 뭐 가만히 있을 때에도 팔피테이션, 체스트 페인 증상 동반돼서 또 팔로우업을 했었고 2021년 7월 7일에 처음으로 BT 어블레이션 시도를 했었는데 그때는 페일을 했고 최근에 23년 12월 5일에 타병원에서 BT 어블레이션 하고도 지금 재발돼서 본원 외래로 내원한 케이스입니다. 약은 플레카이나이드 50ml BID, 프로프라놀론 그리고 베라파밀 사용하고 있다는데
그 아직 그 어블레이션한 디테일은 리포트 못 받으셨고
그때 그 septum 쪽이랑
어떤 쪽이랑
네, 잠시만요.
네, 근데 그 타키카리아 clinical tachycardia is the same as a previous ablation or this is different? Do we know?
뒤에 EKG 실어놨습니다. 그 어블레이션
Okay, go ahead. All right, sorry. Okay.
엑스레이선 특이사항 없는 환자분이고
Okay.
에코에서도 네, 사이즈 괜찮고 EF 괜찮았습니다. 그래서 본원 내원했을 때 레스팅 상태 EKG고요.
Okay.
요게
Just
그
hold a second. Go ahead and read your ECG. Okay. Is it normal for young guy this ECG? Yes or no? That's the first thing we need to know, right? 이 환자 뭐가 굉장히 그 클리어하게 보여요? EKG? You got nice T wave. After that, you have a biggest hump. You see. 무슨 뭐 이거 무슨 웨이브야? Precordial 보세요. Precordial. V2, V3, V4, V5. You see. Second wave 보이지?
네.
이 환자들 U 웨이브가 굉장히 크네. 그죠? T 웨이브. 특히 V2 보세요. Right? T 웨이브가 터미널 하자마자 second hump가 있고 그다음에 P 웨이브가 있지? Now let me tell you a little bit about the U wave. 프리코디얼 리드의 B2나 B3의 아이솔레이드 U에바 보실 적엔 인터프레션 조심하시게 하셔야 돼요. 그 이유는 왜냐면 그들 mechanical artifact from the your apical impulse, mechanical artifact transmission to the anterior chest wall, especially when people have a very thin chest. Okay? 그런데 how do we know this artifact or this is a truly a U wave? U wave most of the time, unless extremely pathologic, they are same axis as the T wave. Understood? 보면은 T 웨이브랑 U 웨이브랑 X가 똑같잖아. 올라가도 이제 positive이지? positive, positive. 맞았어? 그 다음 거 보세요. 다음 B3. B3도 가보세요. B3, yes. 똑같지? B4. B4 똑같아요. Okay? So you usually 3, 4 consecutive leads should be concordant axis. That's a U wave. 근데 mechanical artifact 된 환자들은 could be a biphasic, could be inverted, many other artifacts can happen. That's 그 interpretation 할 적에 이제 that's 하나의 trick that you can look it up. Okay? Okay. Anything else? 환자 electrolyte 이런 거 다 정상이었고, I hope.
예, 예.
Right?
네.
Okay. All right.
그래서 요게 그 12월 어블레이션 전에 있는 가장 예전에 케이지고
Now,
엑시스랑
now it's not making sense, though. 그러니까 확실히 QRS 컴플렉스 B2에도 보면은 number 1, 2, 3, 4, 5 비세 완전 QRS가 퓨전돼 있죠. B3, B2, B2 가세요. B2. 거기 grab that. You just pass. Yes. 그죠? 근데 그때 당시에 타키카리아는 무슨 타키카리아? 당신 그 우리가 지금 프레젠트 디스커션은 타키카리아가 아니잖아. QRS가 어떻게 돼 있어? inferior에서 superior access로 바뀌어버렸잖아. 그지? 이게 what kind of tachycardia this is? 이게 이제 클래시컬 posterior fascicular VT죠? 그죠? 오케이. 그러면은 그 당시에 어블레이션 successful 했다고 그랬어요? term end the study?
이때는 unsuccessful 했다고 나와 있고, 그 다음에 최근에는 지난
오케이.
12월이 successful 했다고, 네,
오케이.
알고 있습니다.
12월 달에는 인덕션이 다시 됐나? 어블레이션 하시고
어블레이션
나서서?
하고서 인덕션 안 되는 거 확인하고 시술
하고 끝날 때 이제,
네, 돼
그러면 what's the
있는데
오케이.
3일 뒤에 재발했습니다.
오케이.
그래서 요건
콜라스.
분원
오케이.
내원에서 TMT 시행하면서 다시 유발이 됐습니다.
same tachycardia. posterior fascicle, right?
네.
근데 그 beginning of tachycardia 지금 여기 지금 onset of tachycardia 돌아가세요. treadmill onset. 좀 그 전에. Yes. 여기 좀 보자.
네.
That's one. Yes. What do you see here? sinus tachycardia 다음에 뭐가 와요? Rapid. Is the same as tachycardia? The different, right?
네.
그러면 이게 무슨 소리야? This could be a trigger, right?
네.
First bit. 그 다음에 gradually morphology가 change하면서 QRS도 바뀌고 특히 그 리드 2 보세요. 리드 2 보시면은 가다가 점점 더 깊어지지 내려하고 그지? SO가 와이드 되면서 R웨이브는 내로 되기 시작해. 만약에 이거를 어블레이션 하시겠다 그러면은 what you need to do? Just ablate the posterior fascicle and you're done? Or we need to do something more? What's the mechanism for fascicular VT most of the time? They say it's come from Purkinje fiber or whatever. It's the fascicle, right? And the first bit 보시면은 this looks like a fascicular PVC. Doesn't, right? They're wider, and then also leader 3 is almost biphasic. Too tall R wave. How do you read this ECG? This is a PVC from where? From left ventricle septum, right? Because your leader 2 is almost isoelectric biphasic. And AVF also, similar. But yeah, you see there's an R wave still. So, and then terminal S is white. So many fascicular VTs, they initiated by the, septal fascicular, near septal fascicular PVC, I should say. There is a proposed mechanism by San Francisco group in the last meeting. They're drawing that maybe the trigger focus is between the two septal and posterior fascicle. That way they can manifest, depending which is orthodromic circuit, whether septal or either posterior fascicle, patient can present both form of tachycardia. That's what they're proposing right now, but nobody knows. And the case that I've seen in Myanmar, in my lab, and some other time I've seen it, many of these patients, they do have a non-fascicular, non-Purkinje PVC trigger. So I really don't know clearly, at least in my mind, whether fascicle is a truly part of tachycardia or just bystander activation reentry. Simply because you could entrain does not mean reentry, because if you look at the literature early days, if you have fascicular VT, you entrain from the RV apex, doesn't work very well. But if you pace entrain from the RV outflow tract or high septum, they do. So whatever the mechanism might be very small reentrant circuit involving septal and fascicle or posterior fascicle nearby area. Is not necessarily has to happen. And so hopefully sometime we can discuss this issue a little bit more detail. But this is an interpretation how I would read this ECG. trigger tachycardia. Okay, so there is a trigger mechanism. So what I'm trying to tell you, after you ablate the fascicles, you need to study, make sure there's no trigger. If there's a frequent PVC trigger, go after, get rid of it. Otherwise, patient tend to have recurrences. That is our current observation I made. So we have accumulation now, total of 27 cases. Okay. And many of these patients, at least in data that I remember, I'm looking at the data for the lecture in April, more than 63% had a PBC trigger. So we have to eliminate, end up eliminating that too. Okay. Anything else we need to comment?
근데 투셀이 ABF 이니셜 Q처럼 보이는 거는 과거에 많았던 어블레이션의 영향이라고 봐야 할까? 아니면 일반적으로 젊은 애들한테 보일 수 있는 노말 배경인가요?
Right. Could be from the scarring from the, extensive ablation. Because if they done 2 sessions of ablation, I'm sure they ablated quite a bit of the subtle area. And I bet you look at the MRI, you're going to be septum is scarred. Okay. I have no question about it. So we do a lot of damage to the myocardial muscle. That's the reason we keep telling you, burn less unless you're absolutely sure. Otherwise, you end up creating scar. And especially young people, we don't know in lifetime what's going to happen to the patient. Okay. We don't have enough lifelong experience in this business yet. So.
그래서 유발됐고 스터디는 TMT는 중단하고 이제 리커버리 페이지였고 IV 딜티아젠 5mg 슈팅하고서 리커버리 27분째 터미네이션 레이트 점점 느려지는 추세이다가 터미네이션.
So you gave a verapamil? What did you do? Just cooling down?
딜티아젠. 네, 딜티아젠.
Delta-Jem 줬어. Okay. So patient is a calcium channel blocker sensitive.
센스티브.
ET, right?
네.
Yeah. 근데 지금 나오는 그 PBC after termination. 지금 바이제민으로 바이제민이 and 트라제민이 almost looks like. So this is the same as clinical VT? It looks somewhat, similar, but it may not be quite similar. It will be interesting to see what is the libelid looks like. But anyhow, I think it's a very so basically calcium channel blocker sensitivity. Patient is young, otherwise a healthy person who had the documentation of posterior fascicular VT ablation, but initial presentation also anterior fascicular or subtler fascicular VT pattern. Okay. Anything else?
운전도 EKG 컨퍼런스는 것으로 마치도록.
Okay. So you're going to ablate this patient sometime?
일단 박현환 교수님 외래 보셨던 분인데 2월 달에 오블레이션 계획 중에 있습니다.
2월 달에?
네.
When the Professor Nogami shows up, I assume. Okay.
아니요, 그날 케이스는 아닙니다, 선생님.
그날 케이스
그날
아니야?
이미 꽉 차 있어가지고요.
스케줄 못 해도
들어갈 자리가 없습니다.
들어가지고. 근데 언제 하는 거야, 케이스는? 2월에?
가야 될 것 같은데요, 스케줄.
Let me know, okay?
네.
I'll be very interested to see this. 내가 한국에 있을 것 같은데, 아무래도.
알려드리겠습니다.
감사합니다.